So today is the 19th, 18th of August, Saturday, a week out from T-SOPs, and in preparation therefore I am going to be running through a cardiac arrest scenario. I'm going to go through my equipment first, since a lot of it is very makeshift and otherwise you may not know what it is. First, we have our beautiful suction unit with its tape measure, suction cording, and the suction catheter, which, as you can see, is labeled thus. We also have a Paisley OPA, a very minimalist King Airway, oxygen and oxygen tubing, a mask for the bag valve mask, the bag valve mask, or the bag for the bag valve mask, a capnometer, which is quite literally a cap, most importantly the AED, which is actually my TENS unit, so it does have electrodes, and there it is, and you'll see more of it when the time comes. And then this is my beautiful Mannequin, made mostly out of Paisley duct tape and whatever came to hand. Because the mouth is not very large, we also have the oropharynx, which is just part of a paper towel tube. And I do own a stethoscope, so I did not have to improvise anything to create that. So I have all of my equipment out here. It's falling all over the place. And so I've arrived on scene. My patient is unconscious on the floor. No one witnessed the arrest. So I come on scene, scene safety, scene is safe, BSI, I put on my gloves. Number of patients, this is the only patient. Nature of illness, cardiac arrest. I'm definitely going to want ALS. You can see my cat is going to be assisting. She's probably going to try and play with my pretend suction tubing. Where was I? Oh yeah, ALS, definitely want ALS. C-spine, I don't know, probably not. If she was helped to the floor, I suppose that if I had an extra person around, then I could have them holding C-spine. So I come onto the scene, I've done all of that. So I say, hey, are you okay? Trap pinch, no response to pain. Check the pulse. Can you see this? Yeah. Check the pulse, check breathing, no pulse, no breathing. Imaginary partner, go get the AED. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, imaginary partner has arrived with the AED. So I'm still doing compressions, but in the interest of demonstration, I'm going to take on the role of my imaginary partner. So I have my AED. Here it is. I have cords that I have to deal with because of this particular device. I have some electrodes. Are these the good ones? I don't want to use the good ones. I want to use the crappy ones. I'm going to expose the patient. I don't care which cord goes to which because I'm not actually going to be using this, except for demonstration. So one electrode goes there, the other goes here. And so chest compressions are still happening continuously. So by this point I've done 5 sets of 30. Because this was an unwitnessed arrest, we have to go for a full 2 minutes before we use the AED. So I will get the airway stuff out. So chest compressions are continuing while I do this. So here is our stand-in oropharynx. Put in the OPA. So that's in place, and then I start ventilating with the bag valve mask. I'm going to rotate here so that it's easier to see what I'm doing. So I have mask like that with a CE grip like that, except with my other hand. And then this bag valve mask, it looks nothing like, or bag, it looks nothing like a bag. So one ventilation delivered over 1 second, and then 2 ventilations. And I'm looking for chest rise, which you can't see with my pretend BVM, but if I pretend that this mask is a pocket mask, there, get a little chest rise. I don't know if that was visible on the camera. Hopefully it was. We can also auscultate for breath sounds. So you do that along the mid-axillary node. Don't eat that cord. Along the mid-axillary line so that it stay out of the way of the chest compressions. I can hear lung sounds. Oh wait, this is supposed to be after we put the king in. Whoops. Yeah, so let's come back to that later. Okay, so it's been 2 minutes of compression, so we're going to turn the AED on. AED is on. Analyzing, so everyone clear. Shock advised, so chest compressions continue while the AED is charging. Then press button to deliver shock. Okay, I'm clear, you clear, we're all clear. Press the button, shock delivered, resume compressions. Um, so I would at this point switch with my partner, because you switch after every time you use the AED, or the AED pauses to analyze. But I'm going to stay here to demonstrate the King airway stuff, because after you've delivered one shock and if they don't show any signs of coming back, then it's probably time to put in a King airway, which my King airway is not really anywhere close to an actual King airway. So pretend that I've tested the valves to make sure that they're working. I've lubricated the King airway, deflated the bulbs, inserted it into the airway, and then inflated the bulbs. And so at this point I can ventilate continuously once every 6 seconds, while chest compressions are also going on continuously. So it would be here that you would auscultate for breath sounds, and also auscultate the stomach to check for gastric inflation. So again, you do mid-axillary location for breath sounds, and then stomach, nothing in the stomach, yay, we're all good there. And then the third way you can check for if your ventilations are effective with the King airway is, so we have our mask and our bag valve mask. Is that gonna stay? And with the King, we don't have a mask anymore, we just have the bag part of it. And you can attach the capnometer to the King airway, and then the bag to the capnometer, and then the capnometer will go from yellow to purple and back again to reflect the carbon dioxide. And I just realized that I did not attach oxygen to my BVM, which is a big mistake. So I will try not to do that on the TSOPs. But so I've attached oxygen to it now, so at least the patient is getting oxygen now. So everything is still going on. King airway, ventilation 6 a minute, chest compressions, continuous. After a while the AED will come back and reanalyze, and if a shock is indicated, then you shock again. If not, you just keep doing CPR. And you transport after 2 shocks have been delivered, or there are 3 no-shock advisories. And then you put your patient onto a spine board and strap them in for safety, because you need the hard surface to keep doing CPR if they've come back and then go back into arrest, and you need to start CPR again. You need that hard surface, so you put them on a backboard, and then you put them on the stretcher. And then you take them off to the hospital, and hopefully they are then revived and live happily ever after. And so that concludes the cardiac arrest scenario. If there is an instance in which suction is required, you just have your oropharynx and then suction catheter. You use the Yankauer hard tip catheter. How do you measure that? I think you measure it like that, maybe. It's hard without an actual person, but it's from the corner of the mouth to the jaw, if I'm not mistaken. I'll have to double check that. Then you mark that spot, insert it no farther than that, sweeping motion side to side on the way out. 15 seconds, and ventilate patient before and after, and leave some time if you have to do it again. Don't do it immediately. Keep compressions going all the while. There are reasons for suctioning might be if they bit their tongue for some reason, there's blood in the airway, you need to get that out before you put in an OPA or a king or anything. So suction needs to be available. And so I think that's it. So I will definitely make sure to remember the oxygen on the BBM next time. It's the second time I've done that, so hopefully I'll learn this time. And on we go to TSOPs.